Okay, the next talk is by Dr. Titus Lau, who will be speaking on managing the tension between safeguarding the vulnerable, MCA and best interest. Sorry, my notes are terrible. Apologies. So, Dr. Lau is Senior Consultant of the Division of Nephrology at the University Medicine Cluster at NUH, and he's also the Program Director for Hemodialysis at NUH, and plays various vital roles in Singapore's medical community, including as the Chair of the Clinical Ethics Committee at NUH. So, without further ado, Dr. Lau, please.
Thanks, Sumi. Good morning. Good to see everyone here. Good to see so many welcoming faces. I think it's been a couple of years that we've not been able to have conferences where we have people, where we see the faces not behind masks. So it's really good to see all of you. I think you realize by now, my first declaration is that I'm not Crystal. And I'm not trying to be Crystal. Crystal will come after me. The second good news is that the incentive for this is that if you stay on for 30 more minutes to listen to me, you will have coffee break. All right? So that should be a good incentive. Apologies for kind of making late changes, but after reviewing the makeup of the audience that we have this morning, we thought that perhaps half of you probably were very familiar with the Mental Capacity Act. Perhaps the other half will be less familiar with the Mental Capacity Act and how best interest is determined through that framework. And so we thought what I'll do as a start is to have a kind of a foundational session. Part of it has been alluded to by Professor Huxtable's talk earlier on in terms of how we safeguard the vulnerable and as well as how to use this framework to determine best interest. I think vulnerable populations, there are many ways of defining this, right? The UN Charter has a definition of vulnerable population, the World Health Organization have the definitions. I think in different countries, different communities, you see different groups of people, you know and you realize who are the vulnerable in your population, in your community as well. What I have here are kind of the more generic, the more universally accepted groups of people whom I think across different countries, different societies will say that yes, these are the vulnerable population and we should make an effort to protect them. And of course, number one is that those who have no mental capacity, those suffering from mental illness, those with learning or intellectual disability, those with physical disability, the elderly who are usually frail and weak, migrants, minorities in the countries, low-income group, women, children, still in some countries, prisoners, refugees. I don't think in the 2 days that we have today, this week or this conference, that we can cover all of this. But I think some of my esteemed colleagues will definitely go through and challenge you in terms of defining best interests for various groups later on, as you can see from the program. So what is the Mental Capacity Act? Firstly, let me just say that this framework that I'm sharing with you is actually from the perspective of the Mental Capacity Act 2008 Singapore, all right? I realized this morning, of course, that there are some of you who are international delegates and audience here. And so in your country, maybe the Mental Capacity Act may be slightly different, but I think the core values and the principles that we have here, which is heavily based, by the way, on the MCA 2005, I think UK as well, all right? So I think across that, I think many things would be uniform, would be the same, and it would be applicable to all of you. So what does it do actually? Why have a Mental Capacity Act, right? So it seeks, and this is a piece of legislation that seeks to balance, kind of to support and affirm an autonomous decision in someone who actually is able to make a decision, right? That's number one. So it does support and affirms that if you have an adult who has capacity to make a decision, we should allow you or that person to make that decision. The second part of this act is that it seeks to protect those who do not actually at that time point have the capacity to make that decision, all right? Specifically, at least in the MCA Singapore version of this, what it says is that, again, the issues it's trying to address is that it wants help the society and people involved in the care of that person to be able to make certain decisions, determine certain decisions for that person who lack mental capacity. It also allow a person who still has mental capacity to voluntarily nominate via an LPA to appoint a donee, so that this person, a donee or more than one donee, can make decision, act on their behalf when one day should they lose the ability to make that decision themselves. And also it allows the court to appoint a deputy to make decision and act on the behalf of a person who lacks mental capacity. All right. It also allows parents with children with intellectual disabilities, to apply to the court to appoint a deputy to ensure that the child's future can be arranged if the parents one day, should they die and then or they lose mental capacity themselves, so that the child with a learning disability or intellectual disability can be looked after still. And finally, I think one important part of this is that it gives a legal protection for acts done for someone if you are doing it in the best interest of the person, of course meeting certain requirements and conditions as set forth by this framework, that you are legally protected doing so. All right. So the next part of this is that it also highlights 5 statutory principles, and I think it's good to refresh ourselves and remind ourselves that we need to do this. I think Professor Huxtable did share this with you in the earlier part of his talk. Firstly, we must always assume that an adult has capacity, and so we must not assume that the person does not have capacity in the first place. All right. So we always assume that the person has capacity unless it's demonstrated that the person does not have capacity. And even in someone whom you feel may lack sufficient capacity to make a decision, you must always try and help and support that person to be able to make certain wishes known to you. All right. So some patients may not be able to understand, fully some of the implications of what the decisions may be. But it is your duty as professionals looking after that patient, whether in the context of you as a clinician, you as a social worker, or you as a caregiver, or you in whatever profession context that may be, to try and help the person as much as possible to reach a decision so that you are able to use that in order to help determine best interest for the patient. All right. And then third one is that again, I think we have said that, and Professor Huxtable has said this as well, making an unwise decision does not immediately construct that the person has no capacity. All right. So making an unwise or what it seems like illogical decision doesn't mean that that person has no capacity. And I think that's something we will elaborate in the next slide. That's something that we sometimes find difficult to do, and sometimes that we forget actually. And again, if we do decide on behalf of someone else, we must always decide in the best interest of that patient. That is a priority and nothing else. All right. And the second part of this is that if we make a decision on behalf of that patient, it's not just the best interest, but also at the same time, it should be a decision that's least restrictive on that patient's freedom. All right, and we'll elaborate on that as well. So you can see that in terms of the principles, statutory principles that's stacked here, the first 3 part actually helps support and affirms and supports autonomy. So as much as possible, we want to allow a person to be able to make a decision for himself or herself. All right. The second part, the 4th and 5th principles applies to patients or persons who are not able to make decisions. All right. And so what happens then? What happens then is that society wants to make sure that decision made on their behalf is in their best interest and is least restrictive to their freedom. So this is the difficult part, I think, for again speaking as a clinician. Many times in terms of interactions with our colleagues, my colleagues and peers, when we come in as doctors, they come in to us as patients and they have a condition, and we feel that the level of evidence to go a certain way of treatment or care approaches or pathway is so obvious, right? That it doesn't make sense for a patient to decide otherwise. For example, you can have a middle-aged young lady in her 30s or early 40s with early-stage cancer of the breast, right? And you say, well, mastectomy is curable, right? Very good evidence to support that. So, but if the person comes back and tell you, no, I don't want mastectomy, all right? For whatever personal reason it is, I don't want mastectomy. I understand this is not the best treatment choice I can make, but that is my wish. And so sometimes it's really difficult for the doctors to understand because we feel always that, that there's a better option out there, and we know it, and we're trying so hard to convince you to see that. But again, just remember, an adult with decision-making capacity can make a choice of their own, whether you feel that this is unwise or illogical, all right? Of course, the context of this is that you have to also make sure at the same time that the person fully understands, the context of the decision as well, all right? So just to make sure that the person truly has mental capacity to make such a decision, and of course, it is also something that you need to bear in mind. If a person actually behaves in a certain manner, where they're always in agreement, so to speak, with you for the treatment, and you feel that those are fair and sensible decisions made, and suddenly one day, the decisions made are very different from what the patient has made in the past, again, you have to then perhaps trigger possibility that maybe perhaps either the understanding of the decisions that's necessary is not being communicated appropriately, or that there may be a change in the capacity of that patient. But again, just remember, an adult with decision-making capacity is allowed to make decisions for themselves, whether you regard it as wise or unwise, logical or illogical. Just kind of remember that decision-making capacity actually is, in the context of the MCA, in the context of clinical care as well, it's got to do with one particular decision at one point in time, all right? This is not a decision, this is not an assessment, this is not an evaluation to decide if this patient is permanently or globally impaired in making decision, all right? So this is just one decision that you need today for the purpose of care of that patient, all right? And at that one point in time. So just remember that. And again, we know from our practice that if a person is not able to decide today, let's say the person lacks capacity to decide now, there is a chance that a person can recover from whatever that's hindering that decision-making process in a couple of days' time. And if that decision can be delayed, there's no urgency to make that decision today. There's something else you can do today without having to make that decision. Then you should delay that as much as possible to allow the patient then to recover and to make the decision on his own or her own, all right? So we shouldn't just jump in and just make the decision so that the care could be efficient, you could discharge the patient early or whatever it is, all right? So if there's a chance you think that the patient can perhaps recover from delirium, for example, or recover from concussion, for example, recover from the effect or side effect of drugs, for example, in the next couple of hours, in the next couple of days, do delay that decision when it's possible so that you allow the person to make that decision. Again, vice versa, a person who's able to make a decision now at this time point may not be able to make certain decisions the next day as well. All right, so the capacity changes, and so it's a day-to-day, and it's decision-specific as well and time-specific, right? And again, also just to remember that there are many questions or decisions that's required from the patients that you're caring for, all right? Some of it are fairly simple and easy, right? Perhaps if you want to eat something now, and the person can tell you yes or no, versus trying to decide on a major surgery, for example, between medical therapy versus a coronary bypass, all right? So the decision can be simple, and thereby the capacity to make such a decision could be easier and easier to assess versus a decision that may be more complex. So as clinicians, as professionals dealing with these decisions, you have to be aware of it so that in assessing the patient's ability to do this, you can make the right decision for the patient. The MCA provides this two-stage test framework for us. One is the first question in terms of decision making is to ask, is the patient suffering from an impairment or disturbance of the functioning of the mind, right? So first of all, the context is that if the person does not, or you don't suspect or does not have any impairment of functioning of the mind or brain, then that person should not have any reason why he or she cannot make a decision for himself or herself, right? So that's number one. So if the answer is yes, there is perhaps impairment to the functioning of the mind and brain, then the next question is that despite that, does the person still have the capacity to make that decision, all right? The decision that you want. And some of these are the usual things that we see in hospitals. I know someone who's suffered from stroke, from traumatic brain injury, perhaps from someone with known dementia, or someone with mental health problems, intellectual disabilities. The one thing we want everyone to remember and remind ourselves as well all the time is that you must not assume patient with impairment of mind or mental disease or brain disease or neurological disease is automatically categorized as someone who has no ability to make decision, all right? So as much as possible, even if they have all these conditions present, you must remember that there are instances, times, and type of decision making or time point where they can actually make decision, make known to you their wishes actually. So do not discount that and do not take that away from the patient. So how do we define what the inability to make decisions, right? So if they're not able to understand the information that's relevant to the decision, if they're not able to retain that information, if they're not able to use that information to weigh, to process it as to come to a conclusion in terms of decision making, and finally to be able to communicate that decision, all right? So this is what is spelled out in the legislation, in the Act actually, in terms of, the components of decision making, all right? So they must be able to understand, they must be able to retain that information. By the way, I think most of you are experienced practitioners here working with patients. Understanding again, you have to grade it and judge it differently in a sense that the understanding of a patient in terms of certain modern science, modern medicine type of treatment may be very different, all right? Someone with low health literacy or someone who has never experienced, for example, what dialysis is, will not be able to fully understand the concept of dialysis. So it is your duty to try and your best to explain it as simple as possible so that the patient can understand it, all right? You cannot expect that a patient will have the same depth of understanding as you do as a professional in terms of the disease context that they are facing. And if they don't, please don't discount it and say that, well, since you don't understand what fully dialysis is, you can't tell me, the physiology of the kidneys and all that, thereby I don't think you have capacity to make this decision, let me make it and take over and do it for you, all right? The second thing is about retention of information. Just remember that the retention of information doesn't mean that you have to remember this for the whole day, right? What it says in the Act is that they have to remember it long enough for them to make that decision, that's all right? So again, there's some subjectivity to it, there's some nuances to this, but again, of course, the patient is expected or the person is expected to be able to retain the information at least long enough to be able to make a decision, all right? So this is the process. There's a decision to be made. You ask, step one, is there an impairment to the functioning of mind and brain? Step two, if there is, then is the person able to make the decision in your clinical opinion, all right? And if the answer is yes, they're able to understand, they're able to retain it to some degree, they're able to weigh it, and then they're able to communicate their wishes to you, then yes, please allow autonomy, support that, and allow them to make it. However, if they are not able to do any parts of that, then a decision maker or a surrogate decision maker will have to make the decision on their behalf if the decision is necessary at that point in time, all right? And the Act tells us that we have to make this in the best interest of the patient. And this is where we come to this part. I think Professor Huxtable has explained to you, nicely about how this is defined very differently in the context of different people, different stakeholders, different situations, different circumstances, right? Obviously, it is understandable that MCA cannot define to you what best interest is in a way, or it doesn't tell you explicitly in a situation, given situation A, B, or C, given a person A, B, or C, that you have, this is the best thing you can do for this person. It doesn't tell us that, all right? So there's no kind of single definition in the MCA Act, except yet we are always asked and reminded we need to act in the best interest of the patient when you are making a decision on behalf of that person who's not able to make that decision. So firstly, who can make the decision, you ask? Who does the Act or at least the society allows to make that decision on behalf of that patient, right? For day-to-day living, simple matters and all that, it has probably be the caregiver. The caregiver could be the person hired to look after the person, or next of kin or family members, someone who's caring for the patient day-to-day, and that person will have to make those decisions every day in terms of what to wear, when to shower, what to eat, what to provide for. So those are decisions that needs to be made in someone who does not have capacity to make them, all right? In terms of healthcare, of course, and medical treatment, the doctors usually and people involved in the hospital, the team and various groups of people in the hospitals, we are always tasked to perhaps be the decision makers in terms of helping arrive at the decision of best interest for the patient that we are treating, all right? And of course, people who already have a nominated LPA donee or court-appointed deputy, they have a say in this as well, all right? So, and they are asked and given the responsibility to make decisions actually as well for the person without capacity, all right? So, I suppose everyone in this room can be the decision maker, everyone in this room can be part of this. So, although the MCA does not give us an explicit or narrow definition of best interest, it does provide a checklist, and these are the steps and approaches we can take in order to arrive at what is in the best interest of the person with no capacity, all right, if you are having to make that decision for that someone else, all right? The first thing is that it reminds us, again, try your best to support autonomy, all right? That's again the overriding principle of this, right? As far as possible, do not take the responsibility of making a decision on someone else if that person actually has capacity to make a decision for himself or herself, all right? So do not take away this privilege and this right of that person based on the age of the person, the appearance of that person, the medical conditions of that person. If I say, even if the person has neurological disorders, psychiatric background, as far as possible, you should always try and allow autonomy, all right, a self-determination. So do not remove this from someone who's, let's say, 85 or 90 and say, well, uncle, you're 90 years old today. I don't think you will understand all this context of treatment of cancer, for example. So let me just speak to your son or your daughter or someone else, all right? So do not take that away from the person, because it is important, it's vitally important, because I think if you look at it, all of us will be vulnerable population ourselves one day, right? And what is it that you think you want for yourself one day when that happens, okay? So please do not remove this decision-making privilege from anyone just based on age or appearance or medical history, right? Yeah, so this is step 2. It tells us, the framework tells us that if you can delay the decision, if it's not urgent, please delay the decision until the person is able to recover from it and make a decision for himself or herself, all right? And again, the second one is that, again, support decision making by trying to make it easy for the person to be able to make that decision, either in terms of the way you communicate to the patient, in terms of the environment that you're trying to make this decision with the patient. Do your best to try and support and make it possible for the person to be able to make that decision, especially patients with psychiatric disorder, perhaps learning disability, intellectual disability. You may need a slightly different context and professional ability in order to be able to reach out to the person and to be able to understand and to be able to derive a decision from that person. All right? The present and past wishes, especially if they're written down, needs to be taken into account. So, it is your duty, your professional duty is actually to be able to try your best to understand, if you can, to see what were the patient's wishes prior to losing mental capacity actually, and whether you can use that part of it to support the kind of decisions you're going to make for the patient in his best or her best interest. Again, you have also to understand the socioeconomic and religious background behalf of the patient, because their worldview and their values to some extent will be kind of molded by that situation and that environment that they are. So you have to understand that, and as far as possible, try and understand where they are, their backgrounds. And so all these things are helpful and important for us to try and understand what would the patient want if he or she could decide for himself or herself. Who can you ask actually, right? So you can of course ask people, the caregiver, whether it's a next of kin or someone who cares for the patient, the professionals, if who's involved in the care of that person, and of course any legally appointed LPA donee or court-appointed deputy as well. All right. So these are the people you can seek an opinion from in order to try and construct the picture of what best interest would be for the patient. I think one of the things you realize as well in your practice is that, and I think Professor Huxtable did share this with you as well, best interests from different perspectives may look quite different, and sometimes it may be even be an area of conflict, right? Best interest from a caregiver, perhaps who have looked after the patient for a long time, who's nearing burnout, may be quite different in a sense, right? That caregiver may just want a safe placement for the person, but with maybe lesser involvement from themselves in the care of that person or in that decision, right? The doctors may decide very differently, right? The doctors just say, well, nursing home application is like weeks away. There are no more beds for these patients. The best is to go home. And for them, best interest may be, so long as I find a safe place for you, I can discharge and empty this bed, and I can have another patient here. So different people may have different biases in them in terms of looking at best interest sometimes, and although we always say that best interest is always in the context of what's best for the patient, but again, when we superimpose that in terms of the situation they're in, the stakeholders they're in, it may come out slightly differently, and sometimes we don't consciously know that or realize that, but you need to again sit back and understand what it is that you're deciding on, and whether that it really is in the best interest of the patient above everything else. And that's sometimes not easy because there's so much pressure and so much demands and needs, and everything has an ethical and professional priority to it as well. All right? And again, just to remind ourselves, if we do have to make a best decision for someone else, try and make one that's less restrictive. What it means, for example, is that if you have someone who fell and fractured the hip, for example, right? And this patient also suffered, let's say, a concussion. Otherwise, the person, this elderly, would be able to decide for herself or himself. Maybe a couple of days' time, the person can actually recover from that concussion or the head injury and make a decision for surgery. So there are two ways of managing a hip fracture, right? One is conservative with its pros and cons, and one is, let's say, surgical replacement of the hip, pros and cons, right? What would be less restrictive is to actually, perhaps if there's no difference, is to delay the decision for surgery and manage conservatively, because then that is less restrictive on the patient's decision in terms of, doing something which is irreversible once you opt for surgical treatment, or you have decided on behalf of the patient that surgical treatment should go ahead. All right. Also, perhaps, if you have a situation where you have to care for someone at home for a couple of days, and that person actually has no capacity, as potentially can harm himself in the environment at home, and there's no caregiver at home. So there are two options. Perhaps one is to tie the person down so that the person doesn't harm himself or herself or fall off the bed. The other option would be to send the person to another family member, perhaps, or somewhere where there's supervised care. So I think in terms of restriction, caring for the person in a different environment would be far better than to try and restrain the person and tie the person down for whatever amount of time that is. All right. Something that's occasionally we grapple with is about life-sustaining treatment. Okay. The MCA spells out that the clinician or the doctor managing this has the priority of making this decision, because this is a decision which carries a fair bit, a very significant consequence, because this is life and death, or in a treatment which is to prevent serious deterioration. All right. And even if there's an NOK who is a donee or a court-appointed deputy, you can listen to their opinion, but they cannot override the opinion of the clinical team if they feel that this is the right thing to do to proceed with life-sustaining treatment for the patients. All right. So this is slightly different from a situation whereby it's not, where the decision does not involve life-sustaining treatment or treatment that is to prevent serious deterioration. For example, surgery for an intra-abdominal abscess, for example, or infection that could kill the patient if you don't do something else. With the exception, of course, if there was a AMD, Advanced Medical Directive, written, then of course that is the explicit wish of the patient before you then would follow that autonomous wish that is listed already. All right. Who should take notes of this is all of us in this room, I think, because if you are part of this care team who has to make this decision for your patients, and there are patients and persons under your care that from time to time may not have capacity to make decisions, and you have to make this decision on their behalf or be part of the team or stakeholders to contribute to that decision making, then this is what MCA is for all of us. All right. Just to reiterate that we are protected by the law so long as we follow the guide, the framework, and so long as we are doing it ethically and professionally, and we are doing it in the best interest of the patient. We are to document the steps. We are to document the reasons, actually. And so if you're challenged, you have to be able to explain yourself as to why you think this is what we decided on, on what basis did we decide on this, and on what basis did we think that this is in the best interest of the patient. All right? And so if you're able to do that, then the law protects us and the society protects us, does not accuse us of doing something wrong against the patient. So I think in summary, the Mental Capacity Act is actually an act to support and to protect the vulnerable. The vulnerable in this case is someone with no decision-making capacity for that particular decision. So firstly, it does support and affirm autonomy of an individual with capacity. Secondly, it's also there for sure to protect someone with no capacity to make this decision. And I suppose the two key areas, and some of these will be elaborated by my subsequent speakers, the debate and the controversy, and perhaps the sometimes inconsistency and sometimes the subjectivity of capacity assessment, who one person may say is capable of making a decision, another person, another profession say, no, I don't think this person is capable of making it. We do face situations like this on the ground, right? The second thing, of course, is what we are here today to debate, actually, and to discuss, is defining and determining what is the best interest. How do we define that from different perspectives and different stakeholders, and how it can be quite different sometimes the way it turns out depending on which side we take. All right? And so, but I think we like what Professor Huxtable said. at the end of this, I think what we want to approach in an honest fashion is that we want to take a holistic approach to best interest, and that's why I think Sumi has, has crafted this team today and, provided you a team of people who will discuss all this with you. Is revisiting best interest and how we can kind of determine this. All right? So I think that's it. Thank you.